So Dr. Duraisamy, one of the experts in the field of sexual medicine and diabetes, he's from Coimbatore, a good friend of mine from SAP. He's holding a office bearer position in the SAP. And so without much delay, I'm just inviting you for the session on a comprehensive management of diabetes-induced erectile dysfunction. Dr. Duraisamy, please take the stage.
Thank you, Dr. Natesh and Dr. Deepak Jumani and Mahendran and Dr. Shivdev. Nice meeting all of you in the late evening. Sorry for the technical issues due to my delay for the first session. Diabetes-induced erectile dysfunction, as we know that diabetes, it's the most common, it's not a disease, it's a lifestyle issue, and India is the diabetic capital of the world. Here there is no word to compare with China or India, whomever, but the number of cases are increasing in India. It's an epidemic. As you know, growing epidemic in India, according to the 2023 study by the Council of Medical Research, total diabetic patient in India, it crosses more than 10 crore and the prevalence rate is more than 8. And erectile dysfunction has a prevalence of 52.5% in diabetic male patients, whereas 15.3% of the population are an additional 136 million people pre-diabetic, and diabetic induced is the future epidemic in India. As you know, diabetes, the value of diabetes, the fasting blood sugar, postprandial blood sugar, and the HbA1c and everything, how to diagnose, how to treat, and everything. As we know, when we studied the type 2 diabetes, the age is more than 50, then it reduced to 40. Nowadays, it changes into early type 2. Young individuals more than 20, 25, practically we face that identify the diabetes. And we cannot say the particular words that early diabetes or what are these. And the thing, diabetes-induced erectile dysfunction, when we identify the diabetes, when the person became diabetes, his blood sugar level was more than 400, 300, or they came to the doctor and says that, sir, we have urinary infection, we have some infection, that it's balanopastitis. They don't know that it's diabetes. They only knows that some infection in the penile foreskin, balanitis, balanopastitis, those things. Then when we check the blood sugar, it's too high. After that only they accept that they became a diabetic. So diabetes-induced erectile dysfunction, it refers to the condition where the individuals with diabetes experience difficulties in achieving or maintaining an erection. Diabetes, particularly when poorly managed, can have adverse effects on various bodily functions, including those related to sexual health. The mechanisms through which diabetes contributes to erectile dysfunction are multifaceted and often involve in combination of vascular, neurological, hormonal, and psychological factors. Always do remember that when the diabetes is uncontrolled, then the diabetic person may not develop the complications. The mechanism of hyperglycemia, as you know, that induced advanced glycogen end products lead to the production of large amounts of reactive oxygen species and reactive nitrogen species, increased oxidative stress and decreased nitric oxide synthesis, cavernous endothelial dysfunction. It leads to abnormal smooth muscle diastole, leading to the development of erectile dysfunction. And as well, the complications, we can differ it microvascular complications and macrovascular. Macrovascular, as you know, that large organs, brain, heart. In heart, if you don't control the dyslipidemia, then you can develop the myocardial infarction. If you don't control your hypertension, then you may develop the cerebrovascular attack. And microvascular, it will be the diabetic retinopathy, nephropathy, neuropathy, and erectile dysfunction, sexual dysfunction, all those, and comorbidities, hypogonadism, depression, polypharmacy, hypertension, dyslipidemia, obesity, and etc. Understanding and addressing the erectile dysfunction in men with diabetes. Erectile dysfunction incidence increases with the age, duration of the diabetes, and diabetes control, how the person controls and manages the diabetes. If the person manages the blood sugar levels under the control, maybe he can live like a normal person. All the diabetic young persons, they develop the complication after 2 years of identifying the diabetes. The diabetes factor, understanding how men's sexual health differs, and how suffer erectile dysfunction from an earlier age, and suffer more severe erectile dysfunction, how worse disease specific health related quality of the life, and be less responsive to the treatment. Always do remember that you have to start the treatment with the insulin, because beta cell toxicity, it responds to the insulin very well. Then you can switch over to the oral hyperglycemic agents. And why diagnosing erectile dysfunction is important? Because identify underlying coronary artery disease, you can have to screen the cardiac disease, and uncover diabetes, and detect dyslipidemia, and reveal the presence of hypogonadism, and identify occult cardiac disease. Symptoms, it may vary: distress, depressive symptoms, decreased self-esteem, or diminished quality of life, and threatened interpersonal relationships, etc. And the comprehensive toolbox for diagnosing diabetes-induced erectile dysfunction, it's always, as I said right from the beginning, blood glucose testing, fasting blood sugar, postprandial blood sugar, HbA1c, and lipid profile, and testosterone levels, and penile Doppler, nocturnal penile luminescence, and dynamic infusion cavernosometry, and cavernosography, and duplex ultrasound, psychological assessment, and urine analysis, and neurological testing, etc. So, medications, the link between the certain drugs and erectile dysfunction, the drugs which may cause the erectile dysfunction, the antihypertensive medications, and anti-anxiety medications, and antidepressants, and hormonal medications, chemotherapy drugs, and antipsychotics, etc. So drugs, when we take, some drugs can act immediately, cause the erectile dysfunction, and something can cause, for example, the drug which you can take for seizure disorders, they can cause erectile dysfunction after some months, or after some years, like this beta blockers, etc. Then other drugs which we are using for the prostate cancer, and anti-ulcer medication, which are the omeprazole, pantoprazole, and antiarrhythmics, non-steroidal anti-inflammatory drugs, and cholesterol lowering medications also cause the erectile dysfunction. And the drugs which can be used for the erectile dysfunction, as we know very well, PDE5 inhibitors, sildenafil, tadalafil, vardenafil, and diagonafil, all they have the mechanism almost the same. They can increase the blood flow, nitric oxide, and the vasodilation, the blood flow to the penis. The action may be the difference. The sildenafil, it can act within 30 minutes, and it can disappear the action about 2 hours. And tadalafil, it differs to each and every person. Some person can say that half an hour before food it can start erection, and somebody says after 2 hours, and somebody says after 6 hours, and somebody says, sir, today even after before 2 hours of sex I took the tadalafil, but I didn't have any erection, but early morning I had very good erection, because its TF is almost 70 to 72 hours. Practically, I see lot of patients that they say that, sir, I took one pill, but it responds for 3 days. I could have the sex every day for 3 days, like that. And vardenafil and avanafil, these are the things, drugs, have less side effects. Same time, they have less effect compared with the sildenafil too. And failure to respond to the PDE5, it may happen in practical. The person can have the addiction, or they can have psychological issues, and they don't have proper stimulation from the female partner, and they can try for formal sex. Don't enjoy the sex, don't taste the sex, only just try to check that they have erection or not, they can have sex or not. For that, so these kind of things, a minimal or absent response to the PD5 is not an uncommon scenario in diabetic patients. Need to be taken appropriately to ensure optimal use, and the physicians must consider all the factors modulating the drug's maximum effect, time to have an effect, and duration of the effect, and maximum dose adjustment, and need of sexual stimulation, as I told, and counterfield PD5 use, and food and alcohol effects in some PD5, and trial of different PD5, etc. Uh, then failure to respond to PD5, we can try it for the lot of trials have been there. They say that daily PD5 might improve the rate response in diabetic patients. For example, if you gave the 20 milligram of tadalafil, if it failure as need dose, then the regular usage of 10 milligram daily usage for 12 weeks improved EIEF score up to 8.2 points. 66% achieved successful penetration, and 58 had completed successful intercourse, etc. Like this large retrospective study involving 136 and 306 men from an American database of pharmacy, authors observed that men with diabetes are 60% more likely to require second-line erectile dysfunction treatments within the first 5 years of ED diagnosis than non-diabetic patients. Diabetic-induced erectile dysfunction patients are twice as likely to require a penile prosthesis insertion compared to non-diabetic men. As like European Association of Urology guideline 2022 says that ED management should be tailored to patient expectations, invasiveness, and tolerability and effectiveness. Therefore, diabetic men should reactive be bespoke treatment plan encompassing all evidence-based therapies. Bioactive components which we use for erectile dysfunction. First, we can say that Icarin, it's horny goat weed extract. It's epimedium extract, source of Icarin classified as a dietary supplement. Potential benefit, Icarin is known to inhibit PDE5, similar to the mechanism of action of PDE5. PDE5 inhibition effect may lead to the increased blood flow, potentially aiding in erectile function. Icarin has antioxidant properties which can be beneficial for overall health. Safety considerations, that Icarin may interact with certain medications, including anticoagulants and medications for high blood pressure. Available forms tablet and capsules. And next we can say, yes, sir.
Yeah, just a reminder that we have crossed 20 minutes mark.
Yes, sir. I will finish soon. Next, most important drug which we practically use more, this is L-arginine. It also mode of action is to produce the nitric oxide and relaxes the blood vessels, and nitric oxide, it's crucial for the dilatation of the blood vessel, as we know, and it increases the blood flow in the penis. And safety consideration, L-arginine is considered to safe when used appropriate amounts. It's naturally found in the various foods and often used as a supplement. High strength and low, we can use from 0.5 gram to 5 gram, and low strength tablets and capsules more than 0.5 milligram. PDE5 inhibitors, we can use monotherapy wise, combined therapy. As we say that we can use the PDE5 inhibitors alone or combined with L-arginine or PLC or L-carnitine, L-citrulline or both, all combination. Same empiric therapies may have role in diabetic patients non-responding to PDE5 without causing any serious adverse effects. For example, PDE5 inhibitors can cause, for sildenafil, it can cause the headache or color blindness, palpitation, and hypotension. Tadalafil, it's very safe for very cardiac safe, and avanafil also very cardiac safe. But the effect varies from the compared with sildenafil. Then the role of L-arginine diet was assessed in single center. I skipped the studies because the lack of time. Another methods which we use for erectile dysfunction, for diabetes-induced erectile dysfunction, it's intracavernosal injection therapy. As we know, we use the papaverine injection, and we use prostaglandin, bimix, trimix, and Invicop, etc. And the efficacy of intracavernosal injection therapy is type 1 we can use, and type 2 we can use, and the dose we can see whenever we have another time. And the complication rates, more than 80% of intracavernosal injection users did not report complication, and positive indication of the overall safety and tolerability of ICI therapy in the studied cohort. Reported adverse effects with plaque formation and mild penile pain, penile curvature less than 30 degree, and bruising and priapism. Infection rates 0% reported about the infection. And another is intraurethral topical application. It's very useful and very useful to the doctors and patients because of the ease administration. And vacuum device erection, actually we know it, and penile prosthesis. The insertion of penile prosthesis represent an end-stage treatment of erectile dysfunction in diabetic patients, as is reserved for refractory causes to ICI or vacuum erection device. Given the potential risk, the complications, and irreversibility of the procedure, comprehensive patient counseling. And most important, just I will take 1 minute to talk about the PRP. PRP is derived from the patient's own blood through a process of centrifugation, which separates whole blood into its different components depending on the different density gradients, red blood cells, leukocytes, and platelets. Platelet having the lowest density is the top layer. A small volume of blood is obtained from the patient into tube that contains an anticoagulant, usually acid citrate dextrose or sodium citrate solution before centrifugation. The uppermost PRP layer is removed and then administered via an intracavernosal injection. The addition of thrombin and calcium chloride to the PRP can be used to activate the platelets before the injection. These therapies repair the damage of penile tissue and promote new cellular and vascular growth. And stem cell therapy, it's most important. Limited number of human studies exist investigating the use of the stem cells in the diabetes with erectile dysfunction, but overall the results are promising. And novel treatments, low intensity extracorporeal shockwave therapy, we know. I conclude that the quality of the evidence is heterogeneous for diabetic patients responding or not responding to the PDE5 inhibitors. The management of all diabetes mellitus with erectile dysfunction should be holistic and patient-centered, with the consideration of optimization of concurrent comorbidities. In those who have not responded to PDE5 inhibitors, several treatment options can be trialed as an adjunct or alternate therapy to PDE5 inhibitor. While the use of stem cell therapy and low intensity shockwave therapy is emerging, randomized controlled trials are required prior to their routine use in clinical practice. Thank you. Thanks for this opportunity. And I would like to thank Federal Med people and the speaker and our moderator, Dr. Natesh and Deepak Jumani sir. Thank you. Thank you so much.